Got it. Thank you, Bruce. Okay,
You're
I'm
welcome.
going to be mindful of time, and we do want to leave time for questions at the end. We've really appreciated the questions that came in after our last forum last month, and today's topic will be based on actually those questions. A lot of you had questions about churn. What is churn? Why is it important? And how do we address it? In that. Again, apologies for the late notice. We did fix our notification system that'll automatically go out before next month as well. And again, at the end, we welcome your suggestions also for future topics going forward. But again, we'll try to make it something meaningful, impactable, and that you can take home and and do it. Again, this is a benefit of our network practices. Again, we like to keep this within our network. Not that there's that much secret sauce in here, but it is something that'll help us. And we do use the analytics and the data from Healthy Seat. Kevin O'Brien is with us again today. Two, I'm just going to briefly go through some things we touched through last time today, maybe your first forum that you attended. Again, do try to see through your website and your portal, you can access the previous forum as well as all the other valuable resources to help you with that. These are our 2024 practices. You know, you're probably on there. We have, I think, 31 practices in the ACO. We do have an oversight board. Many of you on the webinar today are part of that board, or some of you are. Some of this may be repetitious, but again, just to let you know how the governance works with it, the actual practicing physicians, as you can see, have the majority of the voting power in that, and that is by design by CMS. We also use the same committees that the clinical network uses. There, again, your participation on those committees is appreciated if you're on them. If you're interested in participating in any of them, please let us know in doing that. Quality and funds flow will be key probably for this ACO going forward. This time of year, we're closing out actually 2023. As you remembered last year, we submitted the quality metrics, or the MIPS equivalent, for the ACO. There are 10 measures on there listed before you. This is our performance for 2022. Pretty good. And actually that helps in your subsequent reimbursement, I think, for next year. There, I think it's a year plus offset. But your quality directors from the PA Clinical Network are working with your practices right now to help finish and submit this. Your cooperation is immensely appreciated. In that, I'm just going to pause right here, and regarding G-Pro and the quality submission, are there any questions or issues that we need to share, either Wendy or anyone?
Just a reminder, we have till the end of next week to finish the G-Pro reporting. So, and I know we have about 20 practices done. So we got about 10 or so left, 10 or 12 left to complete. So if you have any questions, certainly reach out to us if you have any questions in your reporting process.
Great. Thanks, Wendy. And again, we're trying to work smarter, not harder, and using our data and using our analytics to get us there. I'm going to briefly review, again, coding is essential, and coding properly is key. There, a lot of the stuff, including the MIPS reporting, becomes so easy and so automated if the proper codes have gone through. Likewise, for CMS recognition of the patients and the complexity that you're managing in your patients, accurate and specific coding is needed. So, not generalized diagnoses, but the diagnoses, especially with complexity, that go along with it. And again, your quality directors will help you with those tips and have different things. Setting up your EMR properly so that's automated is key as well. Again, some of the things we touched upon last month, each of you got separately and is on your website where you are in this performance grid. And again, this is the amount of money that CMS allocated to your practice versus the risk that you have in there and your expenses. The green dots and the green practices are those that are spending less than the CMS allocation in terms of utilization. And then again, that could mean two things. That could mean either that your patients are specifically and properly captured and coded, so their risk is fully accounted for by CMS and the allocation they're attributing to your patients. And it could also be the great care that you're giving, the care that's avoiding ER visits, that's avoiding hospitalizations, that's avoiding extra tests. So baked into this is both the risk of your patients as well as the expense in your network. We also talked briefly about different ways to look at it. And you may recall, this is a graph just showing that every one of our practices has a sharp drop off towards the end, and then this is all based on population. So the larger practices are to the right, the smaller practices are to the left, but regardless of the practice size, every practice has a drop off towards the last end part of 5% or so of your population is kind of determining the outcome for your whole practice. And again, the straight part of the graph demonstrates how consistent everybody is for 85% of their patients. The last 15% is kind of where it takes a bend, and the last 5 is where it drops. Affecting that end part is going to be key, and is key, one of the keys to success in this. This is another way of looking at this. Is adjusted surplus by the different categories. And again, this one just shows the higher the arc is in your practice, kind of the more likely you are to save in that. Again, different ways of looking at the data coming to it. We came to a couple of conclusions. We have the 5-point plan from last year that carried forward, that, the annual wellness visits, chronic care management, advanced care planning, behavioral health, and transitional care are key pillars to success. Some of our focuses this year are looking at the impactable utilization. And again, not all utilization is impactable. Obviously, the advanced malignancy patient with a lot of treatments and things like that is mostly beyond your hands. There's not much you can do about that expense, but there may be other expenses within your grasp. Accurate coding, as we said time and time again, and the high priority patients that are highlighted periodically. There is money in real time to be made for that. Advanced care planning, chronic care management, and annual wellness, in particular annual wellness, you can get paid in real time for those visits. And we estimate all collectively, and this is for last year's data, we probably left about, or we collectively left about $500,000 on the table of opportunity in these 5 pillar or these 5 categories there. And that's just regular fee for service, not even dealing with the shared savings or the potential for the quality money down the road. Again, this just highlights a little bit of that 5-point plan, and then the +3 that we're doing, and the recurrent theme that we hear over and over again. The highest specificity and accuracy in your coding will save you and everyone, a lot of time scrambling and trying to figure out what to do. One of the data potential utilizations we talked about was laboratory services and how much at the hospitals they cost so much more, imaging, etc. There, we looked at a couple of graphs real briefly that just shows that the hospitals eat up a majority of our spending, and this now is beyond just the ACO. Actually, this is just the MSSP. This is just the ACO in there. Another way to look at it, again, the hospital systems are the dominant expenses in there, knowing that they spend about 2 to 3 times for the same test that you may be given to get outpatient. And again, looking, and this this is a little bit of a bias graph. It just shows that the utilization of LabCorp, which is the small blue, versus everything else is high. In actuality, we should add on some other testing centers to here, Quest and so forth, because Quest also is relatively inexpensive in it. LabCorp, we do have their ear on, and they are obliging us, you know, wherever possible, where we've identified opportunities, they are willing to help you put a direct feed of, you know, information and resulting into your office and into your EMR, wherever possible. But on to today's topic, which is the churn. What is it and why should we care about it? I'm going to put Kevin O'Brien on the hot seat now. And Kevin, this was the first slide we have, and certainly welcome your explanation. You're muted. Still muted there, Kev. I don't know.
This is Dr. Kevin Carey.
Hi, Kevin Carey. I'm sorry. Kevin O'Brien is who we were looking for. I'm so
I kind of thought that's who you wanted, but it said came
yeah,
up on
I
mine.
did, and sorry about that. Somehow we do not have Kevin O'Brien on the line. I don't know. Keith or Wendy, could you give him a text, or Bruce, just to make sure maybe he too did not get the invite, and shoot it over to
around
him?
10, but that's fine. Yeah, I'll shoot it over again. Yep, right
All
now.
right. I'll do my best now, and Kevin can add to this. Each one of the bars you see in front of you is one of our practices. The churn rate is the y-axis that you see there, and so some of the and it doesn't exactly correlate, but and what is churn? Churn is the number of different patients in your practice assigned to you by CMS. CMS has an algorithm, basically by plurality. Whoever, you know, the number of visits you see is one of the bases that CMS assigns to it. So based on CMS's algorithm, patients will wash in and wash out by assignment. Many of them you may not even know, because they're not presenting to your office. You didn't know they were attributed to you before. They've gone to another doctor now or to another specialist a number of times that outshines or outperforms what your visits are. Sometimes they may even be a snowbird, that they will spend part of their time down in Florida and get a lot of their care down there. Again, that is a possibility. But Kevin O'Brien, I think, joined us. Kevin, I was doing my best to explain churn and your first graph, but feel free.
Okay, great. Apologies, folks. This meeting was 12:30, correct? I just want to make sure I wasn't terribly late.
I just did some background review of what we talked about last month, Kevin, and 12:30 is right on cue for you to come on in.
Perfect. Dynamite. So what, just everybody, I'm in the process of looking at 2023 performance, comparing it to 2022 performance, and looking to give the best advice that I can to Dr. Pagan and all of you in terms of what you need to be focused on right now. I think in the last meeting, we covered a number of different things that we have. I isolated about 10 to 20 patients per practice that need some special attention from all of you. Today, we're going to focus on one of the more systemic challenges, and I'm going to try not to repeat what Dr. Pagan has shared, but this falls under attribution management, and specifically the problem that I'm seeing, and it's not an unusual problem, but it is an addressable issue, and it's an issue that, if not addressed, will make it very, very difficult for you all to be able to achieve the kind of financial recognition that is possible under the CMS program. So focusing specifically on the churn rate, that's as Dr. Pagan was explaining, that's essentially a way of measuring the change in population quarter over quarter. And if I were to, before I get into the details, if I were to simplify this as much as possible, assuming you're delivering the high quality care to all of the patients you're serving consistently and evenly, which is a good assumption. I see nothing in the data to suggest that that's not occurring. In order to be able to succeed, it is much, much easier to succeed if you have a stable population than if your population is changing quarter over quarter, year over year. And we won't get into all of the details of why that's the case mathematically. Just take it sort of as a common sense. If you're taking care of the same patients and you're doing a good job, that's going to play out over time. So we look at churn rate, and one of the measures I look for is to get as close to a 5% churn rate as possible. It is actually not possible to have a 0% churn rate, because especially in Medicare, we're going to have patients who are going to die. So deceased patients count into the churn rate. In addition, we don't want to discourage the addition of new patients. That's a good thing. And in fact, over time, I may adjust the churn rate calculation to focus more heavily on lost patients than on the full churn rate, which is new, deceased, and lost. Right now, I'm using a gross measure of churn rate because the level and degree of change in the population appears to be impacting negatively your ability to sustain and improve your risk scores, which makes it much harder for you to make money over time under the CMS model. But the thing that I want us to focus on today is that when patients are lost, which is the third leg of the churn rate stool, all of your hard work on those patients goes away. It may go to another MSSP. It may just go away to the Medicare program if the patient isn't attributed to an MSSP. So what I want to be able to get into are some of the reasons of why you're losing patients from the MSSP, even though you may not be losing them from your practice. So, Dr. Pagan, can you advance to the next slide? CMS each quarter gives us an analysis of the reasons why somebody was attributed in the last quarter that isn't attributed in the current quarter. And in this case, we're comparing 2023 quarter 3 to 2023 quarter 4. CMS breaks it into 6 different categories. The major one is for PACIN is lost due to plurality of care or lack of plurality of care. What that means is that some other provider, and in your case, some other primary care provider, delivered more of the services that are calculated for attribution to the patient than you delivered on a rolling 12-month basis. So and we'll get into what are those services that that CMS uses to define for plurality in a moment. But basically, they fall into two categories. They're generally office visits, or they're the programs, the codes for the programs that CMS runs, such as the chronic care management, annual wellness visits, advanced care plans, et cetera. We'll get into those in a little bit more detail. But 2/3 of the patients that were lost between Q3 and Q4 were lost due to plurality. Approximately 29% of the patients were lost because they did not have any visit with anybody in the last year. Had they had a visit with a primary care physician that wasn't a PACIN provider, then they would have fallen in the loss due to plurality. 3% of the patients were lost due to transition to Medicare Advantage. So while that's an issue for you for PACIN, that is not a major issue. We can deal with a 3% loss of patients due to MA. And 1% of the patients lost are due to other reasons. They became part of another CMS program. They had Part A only services or Part B only services, or they were no longer residing in the US. That's not a problem either. We can deal with 1%. You will note that very large bar on the far left of the by practice list. That's Manzella. That practice is skewing some of the numbers when we look at it by practice, and they make up about 300 or so of the 551 lost due to plurality. That's a unique situation. We don't need to get into that now, and it will normalize when we look at in about 6 months. We'll be looking at Q2 2024 versus Q1 2024. I believe Manzella will resolve itself by that point. That may play in the Q1 versus Q4 analysis in 3 months. So, but know that that's not an issue. And when that drops off, you will see there's still a significant variation across the different practices, and there's a lot of opportunity for movement. Dr. Pagan, can you move it to the next slide, please? So how do we solve the problem of plurality of care and no visits? It's actually quite simple. We need to get, for the patients that are attributed in the prior quarter, we have to make sure that we're delivering office visits and as much of the big 5 programs, those big 5 programs, again, annual wellness visits, advanced care plans, chronic care management, transition care management, and behavioral health integration. Deliver as many of those as is pertinent for the patient. And to keep things simple, for the next 3 to 4 months, we really want to focus on the annual wellness visits with, where it's appropriate, the advanced care plans. In addition to that, making absolutely certain that you are booking proactive, appropriate office visits with as many of the patients that need more than one office visit a year. And then once we've got that nailed down, we follow it up with the chronic care management, the transition care management, and the behavioral health integration. We've set an internal goal of trying to raise the overall rate for PACIN wide from the low 60s up to 80%. We know we can't get to 100% because there's always reasons why some patients are not going to be able to do things. But we do believe that if we put a dedicated amount of time and effort into this, that we can get to a solid 80% across all of the practices. And what you will see with the practices on the far left side of this graph. There are a handful of practices that are exceeding 80%, in some cases significantly. There are a number that are solidly in the 70s, and there's about half of the organization or half of the practices, about 15 or so, that are 60% or below. So we're going to be going, in addition to working with you on the issues of those very complex patients that we presented earlier, we're also going to be following up with you on how to get the annual wellness visits and the advanced care plans done in the AWVs up to 80%. And we wanted to reserve, I committed to try and keep my talking points on this to less than 10 to 15 minutes so that we reserve the second half of the meeting to discuss where are the barriers and challenges that you're seeing to get that AWV rate up to 80%, so that we can get to work as a team centrally on support mechanisms to assist you. And those answers may be different by practice. So I wanted to open the floor up to that discussion. Dr. Pagan, I think I covered everything that we discussed that you wanted me to cover. And Wendy, same thing. Happy to answer any questions or reinforce any specific topics, but those are my formal remarks for today.
Sure. No, I appreciate that, Kevin. And I think that is helpful. Certainly, if you have a question, you can raise your hand and put it in the chat. Just offhand, Kevin, I just wanted to highlight. So what's maybe not so obvious is, again, is the red and the green. As we said before, represent each of the practices. It corresponds to the red and the green on the scatter plot that you received last month there. Again, if your expenditures for your patient population have exceeded the allocation by CMS, there you're going to see in the red, again, a green if you are less than that. Kevin, looking at this first churn rate, offhand to the eye, it doesn't look like whether you're a red or a green practice, churn rate is a direct correlation. Can you talk to that a little bit?
Yeah,
like here we have a green practice with a high churn rate, correct?
Yeah, that is correct. There is not an absolute correlation between red and green, but I do want to clarify one item. We set the trigger to go from green to red at a 5% margin. And one of the things that I'm going to be looking at is whether or not if I were to soften that hard cut into, if you will, very red to yellow, to orange, to blue, to green, sort of a spectrum, would we see a little bit different result? That said, the point of the churn rate is not intended to go from red to green by itself. The issue is to stabilize the population so that you have a higher chance of durably staying green. And it's very hard. What you would see if we allow the churn rate altogether, if we allowed it to remain where it is in the high teens, you would see, and I showed you this over, say, 12 quarters, you would see green blinking red, red blinking green, and it's pretty chaotic. Whereas if we can get to a more stable population, then what you're doing is you're retaining and harvesting over time the benefits of the hard work that you're putting in. And you will see increases in more greens and more stable greens, if you will. Hopefully that addresses the question, Dr.
No, that's very good. And again, you're basically stabilizing the network, your own practice and the network, so that all the good work you do, it, like you said, is durable and is almost magnified. That what you do will count and will work. If you have a high churn rate, it's going to get diluted. It's going to get washed out in that. And likewise, in this practice, once again, too, annual wellness visit in and of itself doesn't necessarily yield success, or can you read something else into this?
No, you're correct on that. But there's a couple of other things going on. If I were to bring you guys into the craziness that I have to deal with all of the noise of this data, there's a slightly different thing going on with the annual wellness visits on the left side of this graph with the red bars. You may recall in our prior meeting that every practice is subject to that 5% that drops down pretty consistently on a risk-adjusted basis. And some practices have built up enough risk-adjusted surplus to overcome that 5%, and others have either a deeper 5% or haven't built up enough of the surplus to overcome that right-hand drop. So when we go back to that wellness visits, there's going to be two flavors of wellness visits. Those where we're really grinding in and gathering all of the pertinent ICD-10 detail and making sure that everything that needs to happen with that patient is happening. And you're going to see those cases where we get to the 80% and we're doing the wellness visits intensively and properly. They're going to consistently be green. You're going to also have practices where, unfortunately, it for reasons that may vary, including being very, very busy, maybe we aren't getting to the level of detail that we are, but we're still billing the wellness visit because we met the minimum criteria for the wellness visit. But we might not have captured all of the secondary diagnosis codes. We may not have picked up all of the additional needs for care coordination and maybe some interventions or some medication reconciliation or some specialist coordination. And if we haven't picked those up, you're going to get the billing for, the population will experience the billing for the annual wellness visit, but it probably won't yield the value of that wellness visit in terms of the savings that would have, and the increase in benchmark because of the additional diagnosis codes. So you will see that, that noise, but it's going to have a slightly different data signature. Hopefully that I didn't confuse everybody with that, but part of what I'm trying to say is we really need to do these annual wellness visits really, really well. And we really need to make sure that if a patient needs that advanced care plan, that they're getting it, even though it's time consuming. And we need to work with you to make sure that you're capturing the practice revenue that you need to be able to cover that additional time, because you can't be in a position where you're doing work and not getting compensated for it. So we believe there's a way to get there, and we believe that you will realize substantial benefits over time if you do.
Thanks, Kevin, and thanks for the clarification. And again, we don't want to monopolize this. We want to hear from you too. Challenges, as Kevin said, barriers to annual wellness visits, or if there are any practices on right now that actually ways that you've been successful at annual wellness visits, to share that with other members too. So both barriers as well as successes. Annual wellness visit. Again, that's a complete visit, certainly setting up or setting aside enough time in advance, some pre-visit planning to make sure that you can do a thorough advanced care annual wellness visit is important in that. Undoubtedly, as we all know, the annual wellness visit, although it has the word wellness in it, patients start presenting a whole host of other issues, and challenges in that. It's important to isolate that, build that separately, or bring them back to deal with it, so you can at least complete the annual wellness visit as well. But again, looking to you now for barriers as well as successes in annual wellness, what's working. And before we wrap up today too, hearing about other topics or questions that we should make sure we bring forward and highlight to you, either between our meetings or in these monthly webinars. Wendy, anything from your team that you've picked up that maybe you can share for people that maybe are not on the line today, but annual wellness successes or challenges that you might bring forward?
I think pretty much what Kevin said, we need to set aside the time and the preparation to do it completely and correctly if we're going to move the needle here. I don't know if anybody else on the team, I know, I see some people on the call that do this well. If they want to suggest or of any of the suggestions that they have for doing this more efficiently and regularly, certainly chime in.
And I think as a clarification too, the annual wellness visit for Medicare is very patient dependent and needs to take place all year long. You can't do your whole practice annual wellness visits in January through March because it's somewhat contingent upon the date of last year's annual wellness visit. Is that correct?
Yes, it's 365 days.
I think Dr. Pagan, that's a really important clarification. And just so that I can clarify the 80% goal, we're using a rolling 12-month basis. So we're not expecting that all of the 2024 annual wellness visits be done between January and June. We're saying for the period from July 2023 to June 2024, that rolling 12-month period, that we will have achieved 80% across the board.
This is Tracy. I'd like to hear from some of the practices that are successful, or even you, Kevin. We're seeing a high uptake of patients that are refusing annual wellnesses. How do you overcome that barrier?
Tracy, the pregnant pause, I wanted to give an opportunity for somebody to speak up and how they're getting over it. But the one thing I do want to say is that is one of the reasons we've set the threshold at 80% and not 100%, because we know there's going to be a solid percentage of patients. It's going to be more than a couple of percentage points. But what I would encourage the group is to, and I hope somebody does that is on the left side of this graph, speaks up on how they are able to do that, even whether it's in this session or in another session. And that because there are people that are exceeding the 80%. And there's a solid group in the mid to high 70s. So, clearly this is not a situation where nobody wants to do it. So I would encourage us not to extrapolate on the percentage of patients, the small percentage of patients that present that challenge.
Along those same lines, it looks like we do have a question from Dr. Pergolini, how the successful practices incorporate advanced care planning into the annual wellness. I know we have at least one practice on the call that does that very well. I don't know if she's willing to speak on that. Cheryl, I hate to put you on the spot, but if you are willing to to chime in and kind of let us know how your practice is able to incorporate that into your annual wellness, that'd be great. We'd love to hear from you.
Hi, Wendy.
Hello.
Well, as far as doing the advanced care planning, that has to be done by a physician or one of the advanced practitioners. Usually I'll have my nurse, who's an RN, she goes in and does the wellness before the appointment, before the doctor goes in and sees the patient. And then she'll review with doctor any deficiencies, anything that they need. And then that also gives him a heads up that he needs to do the advanced care planning. I also have some tags that I put on the chart just to remind them as well. Sometimes my doctor needs several reminders.
Yes, speaking as a doctor, yes, we do need many reminders in there to keep us focused. So Cheryl, if you can comment too on, I guess pre-visit planning. Obviously a lot of these things take time, and a 15-minute slot for an annual wellness visit, including advanced care planning, probably isn't going to cut it. How much do you manage your schedule in advance?
I allow at least half an hour for an annual wellness exam. And that doesn't include the time that my staff takes preparing the visit. So it does take a lot of time and planning. So that's something you do need to incorporate into your visit.
Understood.
And as far as patients refusing, we just actually had a patient yesterday refused to have one done. And so Dr. Ramanian, when he went in to see the patient, he just reminded her that this is, they're on Medicare and this is part of Medicare requirements that we have to do. So the next time she comes back, I'll just tell her that, you're here today for your appointment and we're going to do your wellness exam as well. That way you don't have to come back for a special visit just for that exam. We always incorporate a wellness exam with an office visit. We never bring them in just for a wellness exam.
That's good to know. That's good to share too. And that may decrease at least the resistance of the patient to come in just for a wellness visit, especially if they're feeling well.
Right.
But if there's something else going on, you catch them. It's kind of strike when the iron's hot there too.
Exactly.
We are at the hour mark. I hate to cut it off. I know many of you have to get back to your work. This is recorded to share. Any other questions, please, send them our way. It helps us plan our next visits. The other little thing I'll mention, is we do work with a company called Evoco for chronic care management. They also do remote patient monitoring. There is significant revenue upside potential in engaging that. Evoco won't get paid anything until after you get paid. It's just a consideration. As you consider and treat your more complex patients and need more touch points between your office visits that you may not have, room in your schedule, or need better surveillance of multiple issues going on. This is an example. Again, all of the tools that we have, available for you as network members are tailored to the network. They are at discounts. They are at, considering our population. Again, they're for your help and your consideration. As we give you lists of, priority patients, that 5%, that may be a consideration on management going forward. That's it for today. I thank you for your time. Once again, we appreciate, the great care that you give each one of your patients and collectively your populations of patients, and keep the questions coming. Have a great afternoon and a great weekend.